Hello everyone, and welcome to today's webinar, Interventional Treatment for PE, Tips and Techniques. I would now like to introduce Eileen Sue, EKOS Senior Marketing Manager, who will be introducing today's speaker.
Thank you, Kat, and thank you everyone for joining us. I'm pleased to introduce today's speaker, Dr. Keith Sterling, the Director of Cardiovascular and Interventional Radiology and Director of Research at Inova Alexandria Hospital in Virginia, where he has been in clinical practice since 1995. He is also an Associate Professor of Radiology at George Washington University and has been a noted faculty member at several national and international medical conferences and society meetings. Dr. Sterling specializes in minimally invasive techniques in vascular and interventional radiology and is a noted expert in the treatment of PE. During today's presentation, he will be sharing specific tips and techniques he has learned for treating PE in what is sure to be an engaging, case-based discussion. With that, I'd like to turn this over to Dr. Sterling.
Thank you, Eileen. Just as a matter of introduction, so this is going to primarily be a case-based webinar where I'm going to show cases that have kind of highlighted our education in our practice of treating acute massive and submassive PE over the last 6+ years. So before we get started, we do have a couple poll questions, and these are my disclosures first. And so here's the first poll question, which is just to kind of get an idea of our audience. And so we did add another specialty here, so just people who are on, you can answer, and when we get a critical number of people, we'll show everybody the results. Great. Okay, so and here's our results. So we did this webinar a little earlier this evening for primarily an East Coast audience, where it's interesting. We had a very it was very cardiology heavy in terms of our the people who were participating. So it seems we have a pretty even distribution of vascular specialties here, and I'm still not sure what other is, but perhaps maybe emergency room or such. So okay, and our next question: how would you characterize your experience at treating PE? And here is that poll. Okay, so again, we have a pretty, share the results. Okay, so again, it seems like we have a pretty broad distribution of experience. So I think we'll touch on a variety of topics that really suit everybody's needs, on both basic and potentially more advanced, and whatever we don't get to, we can certainly cover in the Q&A section. So let me get started. All right, so when it comes to treating PE with catheter-based therapy, a lot of the goals of this catheter-based therapy are really the exact same that have been pointed out before in treating PE with systemic thrombolysis, which is to recover right ventricular dysfunction, decrease pulmonary vascular resistance and pulmonary pressure, increase systemic arterial pressure, such as with the massive PE patients, improve symptoms and survival, first and foremost, and decrease the risk of potentially developing CTEPH, or chronic thromboembolic pulmonary hypertension. And when we're talking about which patients to treat, this is taken from the AHI guidelines, and we're really talking again about massive PE and submassive PE. And just because we do have some people who are new into treating PE, patients with massive PE probably represent 5% or so of patients who present with acute PE, and those are patients who have sustained hypotension with the blood pressure of less than 90 millimeters of mercury for at least 15 minutes, those who are on pressors or really in cardiogenic shock. Minor or low-risk PE, that's not what we're talking about treating with catheter-based therapy. And then submassive, which is a group that I think people are identifying with even more and more frequency as more imaging is being done. And those are patients who have evidence of either right ventricular dysfunction on imaging, such as echo or CT angiogram, or have evidence of myocardial ischemia with increased troponin or myocardial stretch with an elevated BMP. But those patients are hemodynamically stable. Now, when we're deciding who to treat, we can take those categories of massive and submassive and further subdivide them. So when we look at treating massive patients, there's the patients who are absolutely crashing, they're in shock, they're ready to die in front of you. And then the patients who are massive, but they're not crashing. They're obviously very sick, they're hypotensive, but they're what we call a stable massive. And then submassive PE patients are those who are really just teetering on massive, that by all the AHA criteria, they're in the submassive or intermediate risk group, but they're normotensive. Or they have significant RV dysfunction, and they're not necessarily teetering. They may be totally normotensive, but they have a significant amount of RV dysfunction. And then there's the patients who are bordering on low risk, such as those who are completely stable, might have a slightly elevated RV to LV ratio with RV dysfunction, but it might be, if normal is under 0.7 as a ratio, they may be around 0.9. And I think it's important to subcategorize these patients. Now, we do use other things to try and further identify who may and may not be a candidate for which type of treatment. And we have employed, and I'll show you in a second, the simplified PESI score, as because that contains, and you'll see in a second, different criteria which may tell you that that submassive patient might be at increased risk for mortality. And those are criteria that wouldn't necessarily change their AHA criteria of massive versus submassive, but they may help to identify patients who may be on the sicker end of a submassive category. We do look at biomarkers. There are studies that have shown when both biomarkers are elevated along with RV dysfunction, they have a higher incidence of clinical deterioration or requirement of escalation of therapy. We're going to look at patients' bleeding risks. You're going to look at the skills that are available by the physicians in your hospital, as well as the equipment available at your hospital. So this is the PESI score. So on the left, you have the original PESI score, which is a pretty convoluted and scoring system. And the right is the SPESI, or simplified PESI score. And if you'll see, you may have a patient who's a submassive PE, but if they have a heart rate that's over 110 a minute, they get 1 point. And as I said earlier, 1 point or more on a simplified PESI score is associated with a 30-day mortality risk of 11%. So these are things we look at when we're looking at our submassive patients to sometimes drive decisions to treat patients versus not treat patients, or at least identify those patients who we're a little more worried about prior to making decisions. So our typical call, as I'm sure a lot of yours, this is a typical patient that we see. And here's a 46-year-old male presented to the ED with chest pain and shortness of breath. You know, most of these patients are going to come in through your EDs. Blood pressure 116/72, so normotensive, heart rate of 98 a minute. O2 sat, though, on room air was 92%, so definitely trending towards mildly hypoxic. The patient did have a troponin leak of 0.32, and so by criteria, this would be somebody who has a submassive pulmonary embolism by clinical criteria. And you'll see down here they had RV dysfunction. However, we do look at something, the lactic acid. So this patient may at one point been significantly hypotensive. So this is going to tell you that this patient might be on the sicker order of submassives. The patient had a saddle and bilateral pulmonary embolism, and as I said earlier, and you'll see in a second, had an RV-LV ratio of 1.7. And so this is the imaging and a couple slices through the patient's CT angiogram. You'll see the saddle pulmonary embolism and then obstructive pulmonary thrombus really into both the right and left pulmonary arteries. And here you have the four-chambered view, which is easily seen on a CT scan. here's your RV and here's your LV, and you can see that that's your ratio of 1.7. And really, you don't need calipers for this to know that this is significantly increased RV diameter compared with the LV. So our go-to for treatment for these patients has been the EKOS system. And for those of you who may not be as familiar with the EKOS system, what it is a multi-side hole infusion catheter, which is on the top of this right-hand picture. And this is just a multi-side hole catheter where thrombolytic drug will drip in out of the holes. Over here is a close-up of the catheter. So this catheter is highly engineered, and it has a few different ports in it. It has one port where you're going to deliver the drug or the TPA. It has another port for coolant, which is normal saline, usually going in at about 30 to 35 milliliters an hour. And in the center is where this ultrasound core, and this is really the main engineering of this device, where you have these ultrasound elements which are spaced evenly distributed at 1 centimeter increments, and they're going to generate ultrasound energy along the course of the catheter. And you see the catheter comes in lengths between 6 centimeter treatment zone and 50 centimeter treatment zones. For PE, we're primarily using the 12, most commonly and occasionally the 18 centimeter infusion length catheters. So this is going to go in the central lumen of the catheter once you put your wire out. And the whole idea is this is not a mechanical device. It doesn't disrupt the clot. What it does is the ultrasound energy will cause the fibrin strands to separate and allow a much more effective and efficient distribution of the TPA into the clot. And so here's sort of point number one. So what we use ultrasound guidance for all of our venous access for thrombolytic infusions. We've been doing it there for many years, not just pulmonary embolism. In a second, we'll talk about the choice of access. But the point is that when we were participating in the Seattle 2 trial, a paper that was published that came out after that trial really found that the more punctures, ephemeral or jugular, that one did, the higher incidence of bleeding complications, or the lack of ultrasound guidance also was associated with bleeding complications. So basically, the bottom line is I implore you to use ultrasound for venous access, really as a not really an option. So we're now going to do a second poll question, and that is to ask, what is your preferred method when treating pulmonary embolism for venous access? So here is that question, so everybody can hopefully respond. Okay. And here are results. So again, we had 95% femoral in our earlier webinar. So obviously the trend here, at least in the group on the webinar, is that femoral is definitely the preferred access, which I'll talk about. So, and this picture sort of gives it away. Our preferred access, and it's been this way for, I guess, many years now, for PE is jugular venous access. And so here, this is what we do. This shows since over 80% of the patients that we treat are bilateral PEs. We stagger 2 6 French sheets in the jugular vein, again, ultrasound guidance for both their accesses. And the reason we like to use jugular access is a couple-fold. One is because when you do a jugular access, the patient can sit up when they're in the ICU getting the infusion. And since a lot of these patients are short of breath, they feel very comfortable when they're sitting up as opposed to lying down, typically when they would have, say, a femoral vein access. And so that's very comfortable. Two, you are using thrombolytics and you are running heparin in, and different people use different protocols. I'll show you our protocol in a second. But patients can ooze from around the sheaths. And when you have a jugular vein access, and you're sitting them right up, the pressure drops so that you're going to really decrease your issues with oozing around the sheaths, as opposed to femoral. If it's a femoral vein, there's really not much to elevate. It's just then a matter of putting pressure and extra dressings on the sheath if you're having an issue with oozing. So for those reasons, we typically use the jugular vein access. Next, I use just a standard 65 centimeter 5 French pigtail catheter. It's a straight catheter you see here. It's got an atraumatic tip. And the reason I like the pigtail catheter is, one, it's very easy to measure pressures. You're not bumping up with an end hall catheter when you're going through the RA, RV, and pulmonary arteries to get pressures. And the other reason is when you're coursing through right atrium into right ventricle and then out the pulmonary outflow tract, you don't have an issue with catching under chordae tendineae when you're, as if you were using an end hole catheter, say with a straight wire, where that can happen. And there's certainly been reports in the literature where people are doing a fair amount of manipulation to get the catheters into the pulmonary arteries, and then, you know, a chordae can snap. And so I do like the atraumatic use of the pigtail catheter. For wires, I use just a regular 0.035 inch J wire, and then when I'm guiding that wire, I take the back end of that wire, which you'll see here, the stiffer end, and then make a nice gentle curve on the wire, advance it through the pigtail catheter, not out the end hole, but really use it as like a deflecting wire, and it really nicely courses right into, you know, right atrium, right into the ventricle, and then just a little pushing off of the wire, it's going to go into the pulmonary outflow tract. At that point, I'll switch back to the floppy end of the J wire once I'm get my main pulmonary or my pulmonary artery pressure, and then I'll course the catheter directly into the right or the left, whichever way it goes. Usually it does trend to go into the right, but then I'm going to just go into the left the next time, and that's the floppy end. Advance the pigtail catheter further, go into the right pulmonary artery, and measure pressures. And in this patient, you see the pulmonary systolic pulmonary pressure was 50 millimeters of mercury. Then we're going to do our PA-gram. Now, as far as the PA-gram goes, we don't do a power injector run. Quite honestly, you know, you have all your diagnosis from your CT angiogram. We'll use really a 10 cc syringe with half and half contrast and do a hand injection, because really for that, all we're using the PA-gram for is really to guide us to where we want to go. It's really not for diagnostic purposes. And when you have obstructive clot, you really don't need the power injector to do your run. The only times we've used that is when we're prescribed to do that in different trials we've been participating in. But otherwise, it's just really a 10 cc syringe with a contrast injection, and certainly measure pressures. From there, I like to switch to a tight J wire, typically a Rosen wire, 0.035 inch wire. It's a little stiffer. A lot of times you advance it out the pigtail catheter, and that wire is just going to go into the lower lobe pulmonary artery. But when it doesn't, then I will switch to a 5 French end hole catheter, such as a multi-purpose angled catheter, or whatever your catheter of choice is. But typically that's what I'll use. And then I'll advance that into the lower lobe pulmonary artery. I like to use a J-type catheter because it's very atraumatic. And you'll see in this other case that I introduced in the middle of this case, the reason I do that is because when people can be using hydrophilic, such as the glide wire, to get into that perfect lower lobe pulmonary artery branch, and you have obstructive clot, you may bounce into other smaller branches as you're trying to do that. And you could be advancing thinking you're in the one that has all the clot in it, and actually you're perforating right through the wall of a small pulmonary artery, as in this case you'll see this is what it looked like trying to go down into this branch, and instead took that wire and was going into all these other different small branches. And when you inject the contrast, you see a big blob here because that's been perforated. And now, if you have that scenario, you're going to be giving thrombolytic drug, and then those patients could end up having hemoptysis. So this is, again, why I like to use the tight J and not a hydrophilic wire. And it usually does find that lower lobe pulmonary artery branch. Then once that Rosen wire is in place, we'll advance the EKOS catheter over the wire and then put the microsonic core through there, and then start to go to the other side. And really it's then the pigtail catheter is the same maneuver that we just did for the first side, just to go through that. and then we'll do our limited pulmonary angiogram. Here you see there was very obstructive clot, so any contrast that was injected just really refluxed to the other side. We measure the pulmonary pressures, use our type J, and then put that second catheter over the wire. This is our standard protocol, and we learned about this protocol when right before we went live with the Seattle 2 trial. We use 1 milligram an hour of TPA via each catheter, and we do a 12-hour infusion. We also use, and I'll talk about our length of infusion in a second, we also use a very low-dose heparin at 500 units an hour. The whole idea is we do not keep the patients therapeutically anticoagulated during the thrombolytic treatment. Now, I will say, if patients have gotten, for example, a shot of Lovenox, we do not let that dissuade us from bringing the patient to the lab. If they've had it, they've had it, but we don't use unfractionated heparin at higher or moderate intensity doses to keep the patient anticoagulated during the treatment. And the reason we use that 12-hour or 12 milligrams through each catheter is because we feel that that has been established as a very safe and effective dose. And I'll show you some of those, some of that data. It's not really a big data talk, but I'll show you that in a second. So this patient started the infusion at 4 p.m. The infusion of the thrombolytic drug ended at 4 a.m. And so at that point, what we'll do is we have the, and these are all on pre-printed order sets through Epic that we use in our hospital system. And we convert the drug delivery ports, or the TPA, to a normal saline infusion. And we will then immediately convert the patient to heparin moderate intensity protocol, which is therapeutic anticoagulation. And that happens right at that moment at 4 a.m. In the morning, when our first technologist comes in, they will go to the bedside, and I'll tell you how we got there in a second. But they'll go to the bedside, they will remove the microsonic cores, they will cap off both the drug and the coolant delivery ports, and then they'll hook the central lumen of the catheter up to a pressure transducer. We did in our early experience, we did test this. We feel that this correlates very nicely with pressures you get from Swan-Ganz catheters and pigtail catheters in the pulmonary arteries. So we feel comfortable doing this at the bedside. We do not bring the patients down to the lab for a follow-up angiogram and pressure measurements. We did do that, again, very early on in our experience, but we found that those pressures correlated nicely, and so that's what we do. Because the patients had the jugular vein access, the patients are fully anticoagulated at this point. The catheters, the pressures are measured from both pulmonary arteries, recorded, and then both the catheters and sheaths are pulled. And you can see in this case, the pulmonary pressures nicely decreased to 22 on the left and 23 on the right. So in kind of summarizing with EKOS for PE in patients who have massive and acute massive and submassive pulmonary embolism, really most, even from its early years to what we found in later studies, is people are using around the same dose and time of infusion. So in most of these, you'll see that, you know, most of the patients were submassive pulmonary embolism. The TPA dose was averages around 25 milligrams total. The infusion was about 16 hours total, which is probably what for most people are a standard overnight infusion of thrombolytic. The pre-RV to LV ratio in these trials was 1.5 and then went down to just over 1. And the pulmonary pressure systolic went from 45 to around 30. As far as safety, again, most trials found the very same thing. With a major bleed rate in these trials, and again, major bleed in most trials means that somebody needed to get transfusion of packed cells of about 2%, and no intracranial hemorrhages reported. So this is kind of the summary slide. If you're going to take all of that literature, and again, this is more of not a literature, or this is more a case-based talk, but basically we see that about 80% of these patients are bilateral. About 25 milligrams of TPA is that dose that's been seen to be effective in all those trials. About 16-hour infusion, and even though our infusion is typically 12 hours, and all of them have shown a significant decrease in clot burden, RV dysfunction, and pulmonary pressures. And again, the low doses in some of those trials were as effective as the high doses, with one caveat being that a lower incidence of bleeding complications when you use the lower dose. And so Todd Engelhardt and his group published some early experience where they did have a higher dose protocol, and those patients were getting like 40 milligrams of infusion of TPA over that period of time. They found that it was very effective, but they did have 4 major bleeds. And then when they cut their dose down to about half that, around 20, they had similar effectiveness in terms of decreasing pulmonary pressures and RV to LV ratio. However, there were no bleeding complications. And so that was really why a lot of us started using that lower dose of about, somewhere between 20 and 24 milligrams of TPA. And again, major bleed rate will still be about 2% with no intracranial hemorrhages. So here is a case of a massive pulmonary embolism, and just to give you an idea, this is a massive pulmonary embolism that we would consider taking to the lab. So one of the questions asked in the earlier webinar was, if you had somebody who was in the ED and cardiogenic shock, 3 pressors, they coded a couple times, would you bring them to the lab? And I would say, if they're, if they could get TPA, I would give them systemic TPA, because that is effective. And yes, you're going to swallow the issue of possible bleed risk, but you're trying to save somebody's life at that point, and I don't know that you would necessarily have that time to spare. So pushing TPA would be appropriate in that. But we do see this kind of a massive PE patient come into the ED who is very sick. They're hypotensive, but they're a stable massive. They're somebody you're going to want to bring right away. And you see this patient, 54-year-old, acute onset chest pain, shortness of breath, tachycardic. So for that, they get their PESI score of 1, even though this is massive, hypotensive, hypoxic, on and on rebreather. And this is images from the patient's CT, and you'll see that there's a saddle pulmonary embolism with obstructive PE in both the right and left pulmonary arteries. A cut lower down, you see this is the RV to LV ratio. It's 2.5. Don't need calipers for this. Clearly the patient has RV dysfunction. We did our protocol, jugular vein access, that's the PA gram. You see the pulmonary pressure is 59 millimeters of mercury. Again, that's the pigtail catheters. We put our multi-sidal EKOS catheters here from the jugular vein approach. We ran our protocol 1 milligram an hour for 12 hours through each catheter, heparin at 500. And this is what we typically see. So people might be very worried about how much time are you going to give this? I mean, how worried will you be by treating such a patient? And what we have seen is somewhere around, anywhere between 60, most often around 90 minutes to 2 hours, patients will start to stabilize, even with that little of TPA that has already gone in their system. And so this patient at 90 minutes post-infusion, the heart rate dropped, the pressure increased a little, still hypoxic, but now on nasal cannula at 4 liters. The patient found it easier to breathe and speak. And again, that's another reason why we like going jugular, because the patients are a little more comfortable. And the other thing is for these PE patients, we really do not want to intubate them, because intubation and acute PE with this kind of RV dysfunction, they can get very hypotensive very quickly, and so that's something we'd like to avoid. The next morning, this patient, their heart rate was normal, pressure was normal on 2 liters at 99% O2 sat. Because this patient was put in a trial, we did do a CTA at 48 hours post, and that's the cut from the RV to LV ratio. And here's the before and after in this picture. So obviously a very significant change in that parameter. The patient was in the hospital for 3 days and discharged on rivaroxaban. So Xarelto, that is one of our 2 go-to anticoagulants post-PE. We use Eliquis and Xarelto. A lot of that is dependent on insurance and what some insurance companies will pay for and what they won't. So here's another example. This is a submassive pulmonary embolism patient, a 58-year-old male who had a history of prior PE, diagnosed with protein C deficiency, told to be on lifelong anticoagulation, but he's a marathon runner. and he was looking to find an internist who would actually take him off his anticoagulation, and he did. And then he had run a race. He noticed that his times were slow, and he worked for the post office, and he noticed that climbing steps the next week, he was like really winded. So, you know, he got encouraged by his family to come to the ED. He did have a little chest pain, shortness of breath. He knew what it was. He was in a little bit of denial, but he was hemodynamically stable. And this was his cut from his CT, and you could see he definitely had RV dilatation. LV was kind of squished. His RV-LV ratio was 1.8, and you could see here on a coronal reformat from the CT, you could see obstructive thrombus in both the right and the left pulmonary arteries. These were his right heart pressures, and then his pulmonary pressure was 54 millimeters of mercury. And for him, we went femoral. It was one of our earlier cases, and you'll see that we used 6-centimeter infusion length EKOS catheters, and I'm going to talk about that in a second. We did our standard protocol, which was the 1 milligram an hour for 12 hours, and a heparin at 500 units an hour. So one of the things was happening during this case was that one of the catheters kept alarming. And this brought to light something several years ago that we learned, which is the catheter elements, the ultrasound elements are manufactured in groups of 6. So if you have one of these very rare failures of the catheter and you're using a 6-centimeter catheter, you're going to get a catheter that alarms, and then, you know, you're not going to get the benefit of having that ultrasound energy. So as I said earlier, we do use mostly 12 and 18 centimeters length for PE. It would be very rare for us to ever consider using a 6, but you need to know that it is very rare, but can happen that you can get a failure of the EKOS catheter for whatever reason. It is technology, and that happened in this case. We did switch the catheter out and to another 6-centimeter catheter, not knowing this was the issue at the time, and he had his treatment. And then so right after, his pulmonary pressure went down to 41 millimeters of mercury. Again, he was a trial patient. We had a 48-hour post-CT, and he had significant decrease in his clot burden, and his RV-LV ratio went to 0.9. Here, these are the coronal images from his CT. You can see significant decrease in clot burden. Just mind you, although we see that, that is not a driving endpoint. We do not go for complete clot dissolution. Really, the key for this procedure is reversal of RV dysfunction. That's the one that's the independent predictor for mortality. Clot burden is not. And here is his CT post-lysis, and here's the pre and post side by side. It went from 1.8 to 0.9, which was pretty impressive, and he recovered very nicely. In his follow-up, and we see all of these patients in our follow-up clinic, at 30 days he was converted back to warfarin. He had actually at 30 days signed up and ran a half marathon. At 1 year, he's running without difficulty. He's maintained on anticoagulation, and he's completely asymptomatic. Next, here is a patient, and I think, again, there's a lot of things that we learned, so that was sort of the lesson of that case is really the whole 6-centimeter infusion length issue. Here's a patient, submassive pulmonary embolism, 69-year-old male, presented to the ED with chest pain, shortness of breath, and near syncope. He was normotensive, a bit tachycardic, and mildly hypoxic on room air. So we started on O2. He did have a troponin leak. He had a CTA which showed bilateral PE, and he had an RV-LV ratio of 1.1. So, you know, as I said earlier, this is not severe RV dysfunction. He is symptomatic, but we don't treat all these patients. So the decision made for him, and here just I'll show you real quick. Here's the cuts from his CT. So the clot is pretty impressive. Here's his RV-LV ratio, not very impressive. And so the decision for him was to admit him to the ICU, give him supplemental O2, and watch him. So all these patients who are in this category or worse, we do admit them all to the ICU. But we have a lot of dialogue with our pulmonary critical care colleagues about these patients, and we tell them if at any time the patient starts to require more O2, becomes a little more hypoxic, hypotensive, anything like that, let us know, and we come in. We come in for patients who are going to potentially flip into a massive, and we want to avoid that. So this patient did have a repeat troponin. He definitely had a more significant troponin leak, and all of a sudden he required increased oxygen requirement. They called us. He was now on 100% non-rebreather, and so we called our team in. He was starting to become a little more hypotensive. He was still tachycardic. And so prior to that, they had gotten a bedside echo, and I hope this is playing okay for you on the video. His RV was definitely dilated. You could see there's bowing of the septum here. So he was definitely further dilating his RV. We do not repeat the CTA. That's really not necessary. It's a lot easier to get an echo, and that could give you the information that you need. So we did our protocol. We came in from a jugular vein approach. We placed these two EKOS catheters. We ran our infusion in the similar manner that I just told you, about 90 minutes after he started to stabilize. His O2 sat taken from a non-rebreather of 98%. Now he was on 4 liters. I'm sorry, now he was on 4 liters with an O2 sat of 98%. And the next morning he was feeling even better, and you could see he definitely stabilized. We repeated the echo the next day, and you could see from this image that we didn't have that bowing and dilatation of the RV, which was obviously something that was very desirable. So we definitely use echo in these patients, and we do not, unless there's some, certainly not in the acute phase, but we do not routinely repeat the CT angiogram. That's a question I'm frequently asked. Follow-up echo as opposed to CTA, I told you. And again, the key learning point here is it's totally appropriate to admit these patients to the ICU and observe them. We don't treat every submassive pulmonary embolism that comes in. We do observe patients, but any signs of decompensation, we come in to treat the patient. Here is a patient, and I think this is exaggerating some illustrative point I'd like to show. So here's a 67-year-old male presented to the ED, typical symptoms, syncope. He was a little tachycardic, slightly hypotensive, but statting completely normal. He had a BMP elevation, troponin leak, and here this is his CTA. It's not playing, unfortunately. All right, well, here you could see from his CTA, he had a saddle PE, obstructive thrombus in both the right and left pulmonary arteries. And here, this is taken from his lower, you could see significant dilatation of the RV with a really squashed LV. Very, again, don't need calipers to look at this being a significant RV to LV ratio. So, we decide what's our next step. We're going to anticoagulate this patient. These patients all get anticoagulated immediately. And in this case, we decided to do catheter-based therapy. I listed some of the different available therapies depending on your institution. But he was a submassive pulmonary embolism. So we get in there and we measure pressures, and you can see in this case that the pulmonary pressure is 90 millimeters of mercury. So that is very, very significant pulmonary hypertension compared to his systemic blood pressure at that time. But what we did is we decided to place the EKOS catheters, do our protocol, milligram an hour through each catheter, heparin at a low intensity protocol. Now I'll tell you, this was very early on in our experience, and so we brought the patient back down to the lab because our pressures were very elevated, and we switched the catheters out for a Swan-Ganz catheter on one side and a pigtail catheter on the other after 15 hours of lysis. And you could see there really wasn't much change in his pulmonary artery pressures. And even though we did do repeat pulmonary angiography, we really didn't see much benefit or change in his pulmonary thrombus burden. So we were trying to decide what to do. We said, well, let's just continue TPA through his catheters, and we did. And we actually continued that overnight and brought him back down to the lab. And after 30 hours, there was still plenty of clot, and his pulmonary pressure was 100 millimeters of mercury. So we're clearly moving backwards, or not making any, or not having any effect here. So we decided let's do a little mechanical thrombectomy. We did that. We had a little angiographic improvement. Pulmonary pressure was about 90, so not really very different. And eventually, he did get a repeat CT. He was now anticoagulated. He had some decrease in his thrombus burden. And ultimately, he did clinically stabilize pretty quickly, actually, and he was discharged on anticoagulation. 2 months later, he came back to the ED with some symptoms, near syncope, palpitations, but he had normal BNP and troponin as opposed to the last time, and he had this CT. Again, for some reason that video is not showing, but his CT showed no pulmonary embolism, but he had some RV dysfunction with an RV-LV ratio of 1.4. We did check with an echo. They didn't think he had RV dysfunction, and he didn't have any pulmonary hypertension reportedly on his echo. So the point here is twofold. One, there are going to be times where you're going to do treatment and you will not get significant change in your pulmonary pressures. And the reason may be, and usually is because the patient may have underlying chronic pulmonary hypertension. And you may not know that going in. Certainly if you see the kind of pressures we did, we probably should have realized that initially, but you're going to have significant elevation of pulmonary pressures in some people because they do have either chronic PE or chronic pulmonary hypertension, and you're not going to get a benefit. But if you've given them the treatment that you feel, and I feel has been established to be pretty safe and effective, you've given them the treatment. And continuing thrombolytic therapy may just now raise your incidence of having bleeding complications. TPA, even though you stop it, even though we do stop it at 12 hours after the procedure, does bind to the clot. And so even though you're going to stop the infusion, you are going to have some benefit of TPA over the next several hours. And so that's why some people will see significant decrease in the pressures when you do follow-up pressure measurements even the next morning. The other reason this case to me is very, very illustrative is because a lot of these patients come into the hospital, they get assigned the hospitalist, they get assigned the pulmonary critical care, and whoever the endovascular specialist who's doing the procedures. And we see all of these patients in follow-up because sometimes we will have people who had that pulmonary hypertension, and we do make referrals to pulmonary cardiology or the pulmonary hypertension specialist. And then we also, because we are their vascular specialist who was involved in this therapy, we do help make anticoagulation recommendations. We looked at, and we published a couple of years ago, we published 45 consecutive PE, submassive PE patients. And I think the point of this, one point that I want to make is our 30-day readmissions in these patients was 0. And that is certainly not the case in the regular pulmonary embolism population. Pulmonary embolism has a 30-day readmission according to Medicare data of about 15%. Now, I'm just showing you in a small sample size, 45 consecutive patients, we had no 30-day readmissions. But if you're around any meetings or any initiatives in hospitals, you know readmissions is a very key thing to be concerned about. And this is something that you might actually talk to your administration about because I think they would like things where they're not seeing readmissions in patients. So, in summary, right before we take questions, I think you've seen that ultrasound-assisted thrombolysis with the EKOS device for PE in acute massive and submassive PE is safe and effective. People have seen pretty reproducible results, seeing decreased pulmonary pressures and RV dysfunction with this EKOS therapy. I think we still do have unanswered questions, and that is hopefully something we're going to find out through some initiatives looking at some randomized trials in the future about which submassive pulmonary embolism patients to treat and what is the best timing for treatment, as well as what is the best dose of TPA and the infusion time. We just completed the Optimize PE trial, which was a dosing trial looking at shorter infusions and smaller doses of TPA to treat submassive pulmonary embolism, and that's going to be presented at the ATS meeting in Washington, D.C. in May, and so I invite you to look forward to those results. So that is the end of my presentation. This is my contact information for anybody on the webinar who's interested, and I think now we will take questions.
Yes, thank you so much, Dr. Sterling and Eileen. We'll begin answering questions submitted during today's presentation. Moderating the questions today will be Eileen Su.
Thank you, Kat. I have Actually, quite a few questions starting to stack up here, so let's get right to it. We do have a question about fibrinogen levels. Do you monitor patient fibrinogen levels during the procedure?
Okay, so this seems to be a very common question. The answer to this is we do measure fibrinogen, but really the only reason we do that is I do work in a 5-hospital health system. And for all of our thrombolytics, PE, DVT, and acute arterial occlusions, all of our order sets have to include fibrinogen as being drawn. However, we do not use the fibrinogen to impact therapy for PE, mostly because these are about 12-hour-long infusions, and by the time you would potentially, and you usually would not see any change in fibrinogen, your infusion is over. So yes, we do measure it, but no, we do not. It does not impact our treatment for PE.
Great. Some technique questions now. Post-therapy in the unit, when you're starting to take the PA pressures, do you adjust or move the catheters, or are the pressures taken exactly where the catheters are situated?
So good question. So we pull the microsonic core and do it as I said earlier, and we hook it up to a transducer. Now those catheters are usually in the lower lobe pulmonary arteries. It does happen. It is uncommon where you have a wedged pressure where the distal tip of the catheter is really wedged into one of the pulmonary, into a distal pulmonary artery branch. And so usually we do get a tracing, but they do slowly, withdraw it. And you have 12+ centimeters of length of the catheter. So even if you pull it back a little bit, we are measuring it there. And that's the thing that we did when we were comparing the EKOS catheters, like just hooking it straight up to the transducer, maybe pulling it back minimally, measuring the pressure, and we did correlate that with the pressures we measured through Swan-Ganz catheters and pigtails, and found that there was a even correlation. Yes, the answer is we do it. We do pull it back slightly to make sure we're not wedged in a branch. But once we start getting the tracing, that's a pretty consistent tracing that we have to the main, the right pulmonary artery.
Great. I have a question about how many hours post-therapy do you follow with EKO?
I'm sorry, ask that again?
It's like how many hours post-therapy do you follow with EKO?
So usually, if somebody has that, we have those pressures, so we don't repeat the EKO right at that moment. We will like to usually get an EKO before they go, they get discharged. It is nice to have a baseline EKO before they leave the hospital, which we do. So it's not like we needed an emergent EKO at that point in time, because we do have the pulmonary pressures, and I think that you'll have even if they're in the hospital another day, you'll have some further improvement, and so usually they'll get it prior to discharge.
Great. This is a perennial question. Do you place,
if there's any clinical change in the patient, that would be the reason we would also get an EKO. Next question.
Okay. Yeah. Do you place filters in PE patients?
The answer is, the short answer is no, we do not. We don't routinely place filters. Now, there has been some evidence that in a massive pulmonary embolism, it may not be unreasonable to place a filter for those patients. But we do not routinely place filters, certainly not in the submassive pulmonary embolism patients who we're going to treat with lytic therapy.
Okay, great. A lot of curiosity about that last patient that you talked about. If in that last patient who did not have a difference in pressure changes, would you consider surgical thrombectomy?
The answer is absolutely. So in a patient like that, that is exactly where I would be trying to refer the patient. We have had patients who have had no improvement in the acute phase, and then this patient did get referred to the pulmonary artery hypertension clinic, and then referred for evaluation for surgical thromboembolectomy. In our experience, and I know some hospitals are very fortunate, surgical thromboembolectomy in the acute setting has not been something that we have had, a lot of interest in from our surgeons. It just is something that a lot of hospitals don't have interest from their surgeons, but certainly for chronic patients who have that kind of a picture, that would be a very worthwhile consideration.
Great. Do you have a question about your PERT program in a way? Who is called first when these patients are present in the ER? Is it the pulmonologist, IR, surgery, cardiology? How does that work at your hospital?
So we do have, in essence, I think the most famous PERT that I think a lot of people hear about is the Mass General PERT. When we got interested in doing this, like I said, a little over 6 years ago, we had an interest in this. It was really just coming onto the scene, or really just talked about really sporadically in cases. Prior to that, we had been doing, we didn't do EKOS lysis with this kind of a protocol, and the only PEs we got called for were patients who were really crashing, and we did only massive patients, and we would do clot maceration and different techniques. But when there had been some interest in possibly using EKOS or other multicidal infusion catheters for PE, we called a meeting with all the potential people who would be interested in treating PE. So that included cardiology, pulmonology, interventional radiology, surgery, cardiothoracic surgery, all these different subspecialists, ED, of course. And at the end, the only people in our institution who really had significant interest was pulmonary critical care, ED, and interventional radiology. So in essence, that is our PERT team in our community hospital. ED will typically generate the initial phone call. These patients are sick. We do have an intensivist who's going to be that doctor who's going to take care of the patient. We get called by ED, and we get called by pulmonary critical care if this is somebody who we're being asked to consider therapy. So that's our PERT team, and I do say this to people, you don't need to have 10 different subspecialties to have a PE response team. In every hospital, it's going to be very different. Really, as far as the catheter person, it's who's ever interested in doing those procedures. In some places, it'll be vascular surgery, cardiology, interventional radiology. It really is whoever's passionate about treating these patients. But most of those calls do come in through the ED, and if they do come in through the ED and they make it upstairs and they're a submassive patient, we frequently will get called by our pulmonary critical care colleagues.
Great. It's always good to hear about how PERTs are done in different facilities, and yours is a particularly interesting one, I think. Have a question about the dosing of the TPA. How about bolusing TPA before initiating the drip?
So we do not do that. We have not found it to be necessary, certainly with the submassive, because we see the benefit that we've seen in really most all of these patients after that infusion without having to bolus. The only patients who I guess you would consider for a bolus, but it's not like they're getting, this is not something we're doing routinely, and it's very rare, is the patient who's really kind of crashing, and you've made the decision to give them systemic TPA, say in the ED, because you don't have that time, or you don't feel you have that time to bring them to the lab. That's that patient who's in shock or something like that, and they do get their systemic TPA, and if they're going to get the 2-hour infusion, that dose starts, and let's say it's been now 45 minutes or however long, and they've gotten part of the dose, and they've kind of stabilized a little bit. There has been discussion, and we have had patients who they've now stabilized a little bit, and we have brought them to the lab to do even a modified EKOS lysis protocol. So they're not getting the full 100 milligrams of TPA. They are getting something lower. But on a routine basis, for those patients who are, like I said, stable, massive, or I'm sorry, relatively stable, massive, and all the submassive patients, we don't find the need to bolus. We just start the infusion. And I'll, like I said, I invite all of you to await the results of the Optimize PE trial, which will be presented in May, which talks about different dosing regimens and the effectiveness of those different doses and infusion times.
Okay, great. I'll have one more of these chat questions, and then we'll go to the raised hands questions. So it's one about patient selection. The person is asking, what is your threshold or cut for RV-LV ratio for significant RV dysfunction requiring EKOS? And they were asking because your fourth case had an RV-LV of 1.1. So,
right. So actually, I think it was the third or fourth case. So in that case, right, less than 0.7 is normal. Greater than 0.9 is that value that has been associated with mortality in some of the anticoagulation and systemic thrombolysis protocols. So, there's been in the ICOPA registry, if you had greater than 0.9, that was associated with 30 and 90-day mortality. Now, we are making a bit of a leap when we're taking those conclusions and treating some of these submassive patients. However, if it's in that 0.9 to 1.1 and they're very stable, those are patients that we will admit to the ICU, give them their supplemental care, O2 or whatever, and we'll observe them. And in some of those patients, by morning, they may even look better. And then those are patients we do an echo on. And if that RV-LV on the echo now, although we don't repeat the CTA, if now it looks more normal, then those patients will just be anticoagulated. So we're not those are the submassive patients that we are observing and not treating. Now, if we had somebody in the 1.1 to 1.2, 1.3, and they had a PESI, a simplified PESI score of 1 or 2, we might trend on treating them earlier than observing them. And the reason, as I stated, is because some of those features are associated with increased mortality. And there's something about a patient who, although normotensive, all of a sudden, and unfortunately many people have seen these patients where they come in, they look pretty good, they may have some RV dysfunction, but they're okay, and then all of a sudden they flip, and you may not have all that time to bring in a team or do some kind of escalation of therapy at in a timely fashion. And so if there's if they're very tachycardic early on, then that might be somebody we would trend on treating earlier. So I hope that answers the question. We do observe some of these patients for sure, but we do use an SPESI index to sort of raise or lower our threshold for earlier treatment.
All right, so EKOS would like to thank Dr. Sterling and the participants for attending today's webinar, Interventional Treatment for PE, Tips and Techniques. Once you leave today's webinar, you will receive a survey for the presentation, and we would appreciate it if you would complete it and provide your feedback. On behalf of EKOS and Dr. Sterling, thank you very much for joining us today.